Right. Good morning, everybody. Welcome. Good morning, Mr. Stevens. Now, you have two witnesses for me.
I do indeed, my lord.
Very good.
Both representing PAMIS. They've asked to give evidence together as a panel.
Excellent.
And so we've facilitated that.
So it's Miss Graham and, I hope it's Miss or Mrs. Graham and Miller, is that correct? Good. Thank you. When you're ready, Mr. Stevens.
Thank you, my lord. And for the record, the respective witness statements for the two witnesses, their inquiry reference numbers are in respect of Jenny Miller, SCI WT 0460 -5 zeros and then a 1. And then for Pat Graham, it's SCI WT 0417 -5 zeros and a 1. Could I start, please, by asking you both to confirm your full names, if I may start with you, Pat?
My name is Pat Graham.
And my name's Jenny Miller.
Thank you. And you're both content to be called Pat and Jenny for the duration of this session? Thank you, I'm grateful. And your respective ages and contact details are known to the inquiry, so I'm not going to ask you those. You've both helpfully provided witness statements, organisational witness statements to the inquiry. Can I just check you're happy with the content of those as will be supplemented by your oral evidence today?
Yes.
Yes.
Thank you. And are you happy for that evidence to be recorded and published?
Yes.
Good. I should also say at the outset that everything you have said in those written statements, along with the accompanying documentation that you provided and the video, which I myself have watched, the inquiry is grateful for all of that, and all of that will be taken into account. So if there's something that features in your statement that isn't mentioned today, please don't worry, it will all be taken into account by the inquiry. All right. And lastly, in terms of preliminary matters, I should remind you of there's a restriction order in place, so please don't name any other individuals when giving your evidence. If it's a staff member, please try and stick to staff member, or in your case, Pat, if it was your daughter, you just refer to them as your daughter.
Okay.
Is that clear? Okay, thank you. Those are the preliminary matters. I'd like to start, please, if I may. The organisation you both represent today is PAMIS, and I understand that starts for promoting a more inclusive society. Is that right?
Yes.
Yes.
Good. And Pat, in your case, your current position is chair of that organisation.
That's right.
And how long have you held that position for?
I've been on the PAMIS Board of Governors since 2015, and I became the chair in 2017.
And what was your previous professional background before you became?
I was a tax inspector with HMRC.
Okay. And it's fair to say, though, that your own involvement with PAMIS extends quite a bit longer than your involvement with the board, is that right?
Yeah, very much so. I have a daughter with a profound learning disability who's now 35, and my involvement with PAMIS goes back at least 30 years to not long after PAMIS was established.
So you bring your own personal lived experience then, I suppose, in your roles.
Yes, very much so. And I think that the decision that I made to join the board was because at the time I was retiring, and my daughter, who had lived at home, was moving into a housing support service, and so I had much more free time. And my feeling was at the time that because I had been, and my family had been, the recipient of so much support from PAMIS over the years, that it was a really great opportunity for me and my daughter, by association, to give something back to PAMIS and actually to our community.
I see. Thank you. And how would you describe your role as chair in high-level terms? What's involved in that role?
Well, I guess it's a strategic role in that I provide support to Jenny and to other members of staff, but it's also, I suppose, partly operational in that I'm involved in lots of PAMIS activity, lots of research projects, lots of meetings, lots of discussions with Jenny and other members of staff. I'm involved in a great deal of the broad range of activities that PAMIS is involved in. So I don't know whether that's a traditional board chair role or not, but it's what's really evolved over the years. And I think particularly during the COVID period, I was able to support Jenny and the rest of the team in a much broader way than previously, and that's really continued, isn't it?
Thank you. And Jenny, if I can turn to you then, your role is as Chief Executive Officer of PAMIS,
Yes.
is that right?
Yes.
And how long have you held that position for?
So since 2015 as well. I had been on the board previously to that and had been involved with PAMIS since its inception actually, but was absolutely thrilled to get the job.
And what's your previous background before you were
So
taking
I
on that
was
role?
an allied health professional, I was an occupational therapist, and I worked for NHS Education for Scotland as well. So, but my early career started with working with people with profound learning and multiple disabilities. So it was great to return at the end of that career to that post.
So again, useful, I imagine, for your current role as
Yeah,
CEO.
very useful.
Okay. How would you describe your role as CEO? What's involved in that?
Yeah, so I suppose it is leading a fantastic organisation and supporting and facilitating and enabling the voices of a very invisible community to be heard. So a lot of work is done nationally, working with the government and with other organisations. But yeah, and it's been about developing practice, working on research projects, but enabling staff. I mean, I suppose I have a servant leadership. It's leading from behind, enabling staff to really excel in the fabulous work that they do as well. So, but the strategy is probably a big bit looking at how we influence and I mean, it's about a specific group of individuals, but it is about promoting inclusion. And if we can get it right in our local communities, then people with a profound learning disability become visible and are able to take part.
Yeah, you mentioned that word invisible, and we will come back to that, I promise you. So it's in my thoughts. Because yes, I think you mentioned that about 30% of your time was spent working directly with families and then 70% leading your organisation. I think that's what you said in your witness statement.
Yes, yeah.
Right.
I mean, it is great to still roll your sleeves up and get involved. We get very involved in campaigning. We have a mobile changing place toilet, and so volunteering actually with that means that you're out working with families and being able to see what it's like on the ground, really.
Pat, you describe PAMIS as a unique charity in your witness statement. This is paragraph 37. Why is that?
Well, it's unique in the sense that it's the only organisation that solely supports people with profound multiple learning disabilities and their families and carers in this country, and probably from our knowledge of what happens worldwide, it's probably unique in the world. And I think that gives us a very strong understanding of what life is like for people with profound learning disabilities in Scotland. There are other organisations that will provide a degree of support and a degree of understanding about people with PMLD, but PAMIS our exclusive aim and goal is to support that group.
Thank you. And we'll come back to precisely what PMLD means again, but you referenced it there, so profound learning and multiple disabilities, but we'll come back to that. Jenny, you refer in paragraph 5 of your witness statement to a document setting out background information on PAMIS, and for the reference, that's SCI WT 0417. And then -5 zeros and a 2. Drawing upon, or if you can summarise that document, what would you describe as the founding objectives of PAMIS? I mean, that's a question to both of you, but what are the founding objectives of PAMIS?
So it's to ensure that people with a profound learning and multiple disabilities are able to lead healthy and valued and inclusive lives. But we do that through also supporting their families, because if you have a child or an adult with a profound learning disability, it impacts on that whole family life. And I think that's a bit that's often very misunderstood, and they're totally intrinsically linked. So our primary aim, sadly, which was developed 32 years ago, hasn't really changed. It's about hearing the voices of people with profound and multiple learning disabilities and their families, but it's also about enabling communities to include them, and it's also about making sure that any policies and strategies that are developed to include absolutely everybody, which is that group. And I guess what we often say is if you get it right for that group, you'll get it right for so many other people. But it's that bit about valuing and respecting and ensuring they have a healthy life.
anything you would add to that, Pat? Or?
Yeah, I would say also that it's about ensuring that they have a rewarding life, because for many people with PMLD, their lives are about care, because so many of them have very complex health needs as well. And I think probably previously the perception was that for people with PMLD, that was really all they needed, without that fundamental understanding that they have a much greater depth of feeling and comprehension than they are often given credit for. And I think that, you know, you mentioned earlier about why I thought that PAMIS was unique, and I think one of the unique things about PAMIS is that over the years it's an organisation that's evolved and developed. It started off as a family support service primarily, but has moved on massively beyond that. And one of the things that we have innovated and specialised in, as well as our, you know, fundamental, our founding principles, is to ensure that people with PMLD have exciting, interesting lives that gives them an opportunity to learn things and experience things that other people do, and which they previously probably didn't. You know, that there were outdoor activities, lots of indoor activities, things that will develop them, arts and crafts and music and culture, you know, festivals, activities in parks and beaches and all these sorts of things that are exciting, because we should all have the opportunity for something exciting and adventurous to happen in our lives, and they are no different, and they can derive so much from that. That I don't know, does any other organisation do that, Jen? I don't think so.
But they're not simple. They're not easy to facilitate, and it is that level of expertise about understanding how to adapt and develop, and the research that's required in order to enable communities to be inclusive. And what we say is communities don't mean to exclude, they just are not always sure how to include people. Yeah. So we also lead on research, and we take research and make sure that that gets put into practice. So there's been recent research that says actually people's brains develop in a different way from how we thought, and that early development in the brainstem around emotional and imagination and, you know, consciousness happens a lot earlier. So that means actually lots of judgments that were made about people not being able to live a fulfilling life are wrong. And I think that is now coming to the fore, but it also explains why for so many people that lack of expectancy for them to achieve, or that lack actually of expecting somebody to live, has been a real challenge. And I think we're now beginning to make breakthroughs about let's expect people to live a full life rather than just waiting for them to die, which has been quite a dramatic breakthrough.
And I think that's one of the reasons why one example of thing that we've been trying to take forward is lifelong learning for people with profound learning disabilities, on the basis that, well, apart from the fact it's their human right, also they still have the capacity to learn, and they might learn at a different pace and in a different way from everybody else, but why should they not have the opportunities to do things that everybody else does? And everybody else derives value from, and that enables them to live a much better quality of life, just a more interesting life.
Yes. Thank you. And I was going to ask you about the core work of PAMIS, and I suspect you've perhaps both answered that to an extent at least. Is there anything else you would say about the core work that you do in addition to the things you just mentioned?
I suppose one other really significant and important area is that education of the future generation of health and social care practitioners. And actually during COVID, I mean, we provided extensive practice placements because we were able to give them opportunities, but educating people in understanding not only how to work with people with a profound learning disability, but also how to engage families as core members of their team is absolutely fundamental. And I think we believe very strongly that if we develop the next generation, and actually even earlier than that, if we work in schools and with children and young people, we'll develop a workforce but also a community that can be more inclusive. So I think that is education is another very significant part of our role.
And I guess also that educational element extends to I guess the larger organisations in society that will provide those sort of things, because what we're often up against are cultural issues, that mean that people aren't always open to our ideas and our suggestions for innovation and so forth. And that's something that we also have to fight to break through. And I guess, it's not just our people, our guys that are invisible. Sometimes we are also invisible. And so Jenny and I do a lot of shouting, don't we?
Politely, I'm sure.
Yeah, definitely.
Now, you sound very busy. There's a lot on your plate. What is the size of the team, just so I understand at the organisation? What are we talking about?
So we have 20 staff, but not all of them are full-time, so we are quite small. Most of the staff are involved in programmes or projects. So, it's quite a small team, quite a small senior team as well.
Okay. And you mentioned projects. Could you give an example or an illustration of particular projects
yes,
that PAMIS is engaged
so for example, we have inclusive leisure. So we have a member of staff who works particularly on developing communities to provide inclusive leisure. Multi-sensory storytelling is a really big part of our heritage, I suppose. Telling stories is a lot of what we do. So a programme around that work. Family support is core. We have funding for that in 5 areas, but we're also developing at the moment a programme of how we can roll out family support in other areas. So it's all based on getting funding in and projects. Been very fortunate, as Pat said, to have a project at the moment about lifelong learning. What we try to do is to develop that practice. Quite often it comes from research, develop into practice, and then roll it out. And I guess the role of PAMIS is to enable other people to do it and then to step back.
Do you want to mention changing place toilets?
Oh yeah, changing place toilets, I suppose. So changing place toilets are these larger toilets that have an adjustable height changing bench and a tracking hoist, because actually having your personal needs met with dignity and respect is one of the biggest barriers for people going out into the community. So PAMIS 20 years ago started the campaign to get these into every community. We've still only got about 250 in Scotland, but Scotland was the first country to put it into planning regulations to say it had to come. So we still do a lot of advice and support with architects and communities that are wanting to build those facilities. But without that, you don't go anywhere, or you change your child on the floor of a toilet.
Yes. So transformative for those families that are obviously affected, yeah. Understood. You mentioned family support, and in your statement you talk about family support directors, and we'll come on to the impact on your staff of the pandemic. But what's their role, family support directors?
So they will only work with families who have a son or a daughter that has a profound learning and multiple disabilities, and it is fairly varied. I mean, I think there are some fantastic organisations out there, but lots of people don't really understand that unique role of having a child with very, very complex needs, or an adult with very complex needs. So they provide emotional support, a lot of support around transitions as you move from children into adult services. It's a big black hole, and you come from a often very secure service where there's lots of services wrapped around a child, and suddenly you're into adult services and trying to get appropriate care packages. We've been having debates about guardianship, supporting families so that they still have a say in what their relative does, providing emotional support when, sadly, sometimes somebody dies. So, actually the family support starts from birth and goes on well beyond the lifetime of that individual. Really picking up, because families have so many skills that they can still bring, but that bereavement and loss is quite a unique type of loss as you lose your caring role. We've also been looking at how we support family carers back into employment. So very, very wide and varied, and families come, with issues. And we provide sort of inclusive leisure. So, over the holidays, there's often clubs, and that's a lovely way of bringing families together to support each other, but also to be able to provide purposeful and meaningful and fun activities for their sons and daughters. So it is very varied, and at times can be, at the moment can be incredibly intense with, families suffering with their well-being, and also, really complex care cases. How do you support a family to remain resilient, throughout that?
I just wonder if it might be worth mentioning at this point what a person with a profound multiple learning disability might be like in a family setting. I guess that would have been, if we had been able to show the film, that would have been evident, but what that leaves us with is trying to explain in probably inadequately in words what that entails. So in a family with somebody with PMLD, that person is likely to be non-verbal, will very often be non-mobile, and if they are mobile, that can be very, very challenging because of the level of their learning disability. They're very likely to have complex health issues. They will need 24/7 care. There'll be a need to manage medicines because many of them are on very complex medicine regimes. There may, for some of them, be invasive procedures. There will be moving and handling issues. Many will have severe epilepsy, where they'll have seizures on a daily basis, sometimes multiple seizures on a daily basis. There will invariably be postural care issues, particularly for those who are non-mobile. And frequently, life-saving care is a day-to-day component of that family's life. And at the same time, family carers, and quite often they're single-parent families, are having to cope with normal, everyday life, including caring for other children, maybe caring for other relatives, particularly during COVID, possibly working, and managing a home and finances that, the same as everybody else does.
Yeah, thank you. And that was exactly what I was going to come on to, was just defining PMLD. No, it's absolutely fine. That's what we're here for. Because yes, you refer again to a document in your statement which kind of outlines the points you just made, and for the record, that's SCI-WT0417-5004, and that talks about the diversity of that group of individuals. And that was exactly what I was going to ask you. It's the human element I wanted to explore, because you've talked about some of the common characteristics. We can come on to those, but you've covered some of them already. But it was that flavour I was wondering if you could give of the things that those individuals enjoy doing, and what they spend. And I think you both have talked about this to an extent a little bit already today. But that was what I wanted to ask you, just about what activities they enjoy and do, because that doesn't necessarily leap off the page, and it's helpful to hear from you what that is.
And it's as diverse, isn't it, as you and I. I mean, it is really interesting that for one individual, it might be activities. I mean, I always remember going and watching in awe of people catapulting down a snow slope in a wheelchair. For some young people, they want that thrill. We've had to quite often think about changing place toilets and the hoist and how that might be used, because actually whizzing across a room is really enjoyable. I mean, I guess it's all the proprioception that you're picking up. But equally, multisensory storytelling or being out with friends. Or I mean, it is absolutely diverse, but I guess the trick is being able to make that activity inclusive and accessible. But it's the sense of humour and the ability to have fun and make people laugh, but also the ability to profoundly impact on other people's lives as well. Yeah. But it is very diverse.
It's very diverse, but it's very, very challenging, because for each of those activities that Jenny's talking about, if you have somebody with PMLD in your house, the amount of effort that you have to go to get your son or daughter, your child, to an event like that it's a mammoth task. That list of things that I sped through really quickly. Yeah. Each of those things can take many, many hours a day, and family carers will spend most of their day caring, and quite often a lot of their night as well. Which is why I guess we'll be coming on to talk about COVID, but that was before COVID. So you add COVID into the mix, and it was horrendous.
Yeah. Well, just one other thing to add is it also, family carers understand their relative and know that sometimes that can rhyme, rhythm, repetition. It can take months and months to get somebody to engage in an activity. And I think some of the issues that we have, and why we're so keen on education, is that sometimes you have to educate fantastic paid carers, but who haven't had that experience of understanding that don't just try it once, you need to try it over a number of times. And just because somebody didn't want to go to storytelling one day doesn't mean that they won't want to months down the line.
Thank you. We heard earlier about the founding objectives of PAMIS and what those are, and yet it was noticeable in both your statements you described those with PMLD, and indeed today you said again about those people being marginalised and invisible. I wondered if you could just say a little bit more about why you think that is or why that is.
I mean, part of that is absolutely to do with the fact that there are no changing place toilets. So you don't see people wandering around your communities because there aren't inclusive and accessible facilities for them to go to. I mean, we've been really lucky in Edinburgh. We've been doing some work with the National Galleries where they've now got a changing place toilet, and they've opened up, you know, some of their exhibitions, and they've even exhibited some of the folk that we work with, their work there. But if you don't have communities that are open and inaccessible, people don't see that group. And I think, Pat, you'll probably explain a little bit more, but quite often families that have children with a profound disability, their social networks and support all falls away. You know, trying to maintain relationships when you've got such a heavy caring role is really, really difficult. And we often hear families talking about the fact that even their families don't always understand, and suddenly people become either embarrassed or they don't know what to do or how to help. And I mean, you'll probably be far better to explain that, but people tend to walk away. And then if you're a single parent family, how do you manage to get out?
And you're much more likely to be a single parent family if you've got a child with PMLD, because that is a huge stress on a relationship, and often relationships don't survive, and I can testify to that.
Thank you. Jenny, on a related theme, I wanted to ask you something you touched on in your statement about the NHS frailty scale that came in, just that seemed to me relevant to what we're talking about now and quality of life. I wondered if you could talk about that being a highly stressful time, the introduction of that. Could you perhaps explain what that is and why it was stressful for those with PMLD, please?
It's really interesting, actually. It evokes emotion straight away. And what has been very interesting recently is actually up until 2 years ago, if a child or a young person died and they had a profound learning disability, nobody investigated their deaths because they were expected to die. And now that begins to make so much more sense about a frailty scale that was being suggested to be put in place. And I think our anxiety was that somebody was going to make a judgment about who would get treatment if they had COVID and who wouldn't. And considering now that people, the whole attitude seemed to be that, well, actually, if you've got profound disability, if you've got cerebral palsy, you're not going to make it. And families spend every day having to, well, you know, take them home and give them lots of cuddles because actually they're not going to survive. And you know, Mum the other day said, why can't we just talk about people living rather than expecting them to die? And people are living far longer lives now. But that frailty scale absolutely shocked us to the core, because we know that people don't always value, and with all due respect, healthcare practitioners don't understand the value that somebody with a profound disability has, the value of their life and the value of their life on other people. And I think we and families we were having a lot of calls of people just being so worried that if their relative ended up in hospital with COVID and you know, with needing ventilation or having very severe respiratory problems, and there was a queue, that actually somebody would say, well, actually it's going to be difficult to ventilate that person, and maybe her quality of life isn't that great. You know, if we're going to have to make a judgment, then that person won't be the top of the list. And I think families, and we were absolutely terrified. And I mean, just one example, I had a student that came who had read a lot of medical research and was talking about quality of life. But by the end of his placement, he realised that a lot of the quantitative data was no good unless you looked at the qualitative data. So he spent time with families. He looked through their digital passports. He saw films of them at the Edinburgh Book Festival. And he realised that if you were making a decision just based on that clinical judgment, you had missed out all the qualitative data, and that actually you wouldn't be making an informed decision. And I think that was our worry, that people weren't making an informed decision. So that was a really scary time.
And I think added to that was really serious concern and fear that families experienced about the lack of acute hospital pathways and the difficulty of making sure that your child, when I say child, I'm talking about child of whatever age, would be appropriately looked after in a hospital setting, whether that was in an ambulance or in A&E or if they were admitted to a ward, because the thinking at the time was that nobody was being supported. Everybody was on their own. But if you think about somebody with a profound learning disability, I mean, we are always very reluctant to put a developmental age on our people because it's really difficult and doesn't really tell the whole story. But just for the simplicity of the argument, if you were to think about putting a 2-year-old in an adult's body in the back of an ambulance without any support, in A&E without any support, in a hospital ward without any support from known carers, they can't tell you what's wrong with them. And actually, for them to be in that situation, there is something wrong with them. They have communication difficulties anyway, and to be left abandoned, as some of them were, and some of them might have been, without anybody to support them was a horrendous scenario, and it was the sort of thing that gave us nightmares. And actually, I'm sure Jenny would be able to confirm that some people did end up in that position, and we, as a family, and in conjunction with PAMIS, had been fighting with our local authority to have acute hospital pathways put in place, which they declined to do for many years, and particularly during COVID, it became so much more important that people with PMLD were looked after properly. And the reason for continuing to delay and getting that sorted out was that there was a pandemic, but failing to realise, the irony being, of course, that in a pandemic it was much more important, not less important, for there to be appropriate pathways for people with profound learning disabilities or acute communication difficulties, whatever that might have been. And it seems conceivable that the higher mortality rate for people with PMLD can be attributed to the failure to ensure that they're appropriately cared for in hospital settings. And it's not anything that would be really difficult to resolve. It's something that would be quite easy to resolve. And in fact, even if it weren't, it's enshrined in the law and should have been resolved. And that's in my particular local authority area, but I guess that applies across Scotland as well, and that's why PAMIS were supporting our family in doing that. But it was a huge worry, and continues to be.
Yeah, because I was going to ask about acute hospital pathways, and did you have families specifically coming to you with concerns about that lack of accompaniment during the pandemic? Is that something that PAMIS encountered, yes?
Yes, and even with guidance that came out, I mean, we worked very closely with civil servants at the government to try and, because that was an issue that was coming up, that people, were worried about what would happen, and then when it did happen, it was really difficult, and people, I mean, it was interpretations at local levels were different, and people were either their relative was going in without them, or they were having to fight to be able to go in. And then sometimes that would even change on a shift, that they were allowed in, and then they would go out, and then the shift would change, and somebody would say, well, no, that isn't what the guidance says. There was a lot of different interpretations, but it was a real issue.
And I think on the back of PAMIS and PAMIS representations to the Scottish Government, the Cabinet Secretary issued a very detailed letter to all HSCPs and NHS services to ensure that people with profound learning disabilities were supported by known carers in hospital, but actually our experience and our understanding is that was pretty much ignored.
Mm-hmm.
Thank you. And just to tie it off before we move on any... Sorry.
And that is because the instruction, if that's what it was, came only in the form of a letter from, albeit a cabinet minister, but that's of no legal power, is it? simply because a cabinet minister says do something, you don't have to do it. To make someone do it, it has to be in a statute or at least a regulation.
But of course, it was in the statutes and the Equality Act.
I noticed that
Yes,
you'd said
yeah.
that there is a legal duty, but I
Yes.
rather infer from what you're saying that yes, that was a pre-existing problem that wasn't being implemented before COVID, but was exacerbated, I think was your words, by COVID, which I readily understand. And then you made representations, and the cabinet minister admittedly wrote a letter, but again, as I've already said, that's nothing that is mandatory on the recipient of the letter.
No.
Yes, exactly, and that was our experience. But we had been enormously encouraged by
Oh, no doubt.
the cabinet minister's understanding of the issue. But we did speak to the heads of many HSCPs after that, and they they acknowledged that they'd received the letter, but hadn't realised what the background was, and so therefore hadn't done anything about it.
Well, I could turn your proposition on its head by saying that if the cabinet minister appreciated there was a problem, then actually writing a letter isn't the most effective way of doing something about that problem, which is accepted.
Yeah.
Yes. No, couldn't agree
I think
more.
the letter did say, though, I'm not asking you, I'm telling you, and I don't care who pays for it, you can sort that out
Well,
afterwards.
that's
And
no use, with respect.
Absolutely, but it was a letter that went out. But what the Health and Social Care Partnership said to us is, until Pat and I did a presentation, they said, oh, we didn't understand why we got that letter. So they hadn't understood the problem, but that again showed the invisibility of our group. You know, we thought, well, it's pretty obvious why you got it, and, you know, talked about a specific group, but that group is so invisible that they said, it hadn't dawned on us that would be, and it still doesn't dawn on people that it is
But
an issue.
it should dawn. I mean, I appreciate it's not really for you to say, but it should dawn on a cabinet minister. If a cabinet minister thinks it's sufficiently important to write saying this is important, I don't care how you pay for it, do it. That of itself has no mandatory compulsion imposed on it. And if they think it's that serious, you could argue, I would suggest that they should ensure that it is mandatory.
Yes.
Something we'll have to think about, but
Indeed. I just wanted to come back briefly on the NHS frailty scale. Do you recall what the timing of that was, and also what the eventual outcome was in relation to that scale? Because I think we moved off, and I just wanted to
It was
that.
quite early. I can't quite recall, but it was quite early on, because I mean it was when we were meeting as groups of organisations. So I think I remember it being very dark. So it must have been early on in that March, April time, because I just remember it being a dark day, when we were discussing it. And then it was overridden, I think, in Scotland really quite quickly. I mean, there were a lot of organisations that came down on it, but I think the issue was, I'm still not sure that always filtered down, that people were still making those comments. I think we picked up from some families that somebody had quoted the clinical frailty scale to them in a Scottish hospital later on in the year. But I think it was pretty quickly quashed. But sorry, I can't remember.
No, that's fine. That's fine.
Just remember it being a very black day.
Yes, more ways than one.
Thank you. So I wanted to move on now to the impact of the pandemic on your organisation and the services you provide. I mean, Pat, for example, you described PAMIS as an outward-facing charity providing valuable face-to-face contact and interventions to help families and carers, at least in normal times. You've also said today, and it's in your witness statements, both of your witness statements, and the accompanying documentation, you described the complexity of the healthcare needs of those with PMLD and the high packages of care that they require. So then the pandemic then hits. What is the impact upon the resources that the PMLD community require when that happens? Health and medical and social care. What was the impact of that? I appreciate that's a big question, but
Well, it just all stopped overnight. I think I remember you doing a presentation very articulately saying, in the blink of an eye, everything
went. Yes, and I suppose I spoke earlier about what life is like very briefly what life is like in a PMLD family, but I think it's in normal times or non-pandemic times, a PMLD family is based, what you do is you build a framework. and it's a really fragile framework around which you hang on all the things that you need, and that framework depends on input from social work and the NHS and allied health professionals and schools and day services and respite and short breaks, housing support and the third sector. And on the 23rd of March, that framework just collapsed. It collapsed around our ears. And for those with a family member who was still at home, there was no one to ask for support and no one to turn to. And for those who were in a residential setting, it would be months before we would get to see our family members again in any sort of meaningful way. So it was a terrible, terrible time. So life for a PMLD family is frightening at the best of times, and you do what you can to make it as good as you can possibly do. But actually, for those families who had a son or daughter at home, whatever age that was, it was absolutely terrifying, because you depend on all those services, not just for general well-being, but for physical and medical help, and mental, emotional, cognitive help. All of these things rely on other people. Lots of families have become very, very skilled in providing all of those things, but you still need input from lots of experts, and those experts just disappeared. Nobody knew where to find a social worker, and it was just gone, and it was absolutely devastating in my family. My daughter was in housing support, so we didn't get to see her for 3 months, and that was terrible for us. It was much more terrible for her, but actually it was much more frightening for all of those people who had a family member at home, who were trying to look after them and do all the medical support and all the things that they needed, and keep them moving, keep them active, because often their postural care and just general well-being is dependent on them being able to move, and they couldn't move. They were stuck in houses. And I wonder, because we've read statements from our staff about what it was like, and I wonder if there was something that jumped out at me in one of the statements, and I wonder if I would be able to read that, because it would give you a bit of a picture about what it was like in families' homes at that time. Because I guess this must have been slightly later on, because she was actually in families' homes. But what she said was about unpaid carers. There was an expectation that unpaid carers would just keep on going. Sadly, unpaid carers are human, like you and me, and are not machines. They just can't keep on going and going and going. There wasn't any acknowledgement of the vital roles that unpaid carers had throughout the pandemic. They weren't recognised, they weren't appreciated, they weren't valued, and they weren't mentioned. And she goes on to talk about what it was like in families' homes, and she said what was available to families at home was what they had pre-pandemic. That is the bottom line. Lots of young people's postural care requirements are met within their school environment or within their community service environment, such as day services. Many families don't have access to this kit at home, some because they physically don't have room for it, some because they physically can't safely support their young person into a standing frame or side-lying board safely, as they're a single-parent family. Supporting somebody with PMLD may require a range of specialist equipment, as well as resources like gloves, aprons, continence pads, feeding tubes, IVF fluid-giving sets. This is all provided in bulk. Often bedrooms and hallways were quite tightly packed with what might be called stock. Many of the PAMIS families support the families PAMIS support live in social housing, so they're not living in particularly spacious accommodation. So even if families had wanted to ensure postural care plans were being carried out, they couldn't. And this came with the knowledge that every day this would impact on their loved one, that this would have a detrimental effect on their posture and possibly their health. And indeed, this proved to be the case for many families. And we know of instances where individuals' postural care was so compromised that they have died, or that their quality of life is significantly reduced, and it will hasten their death. So it wasn't. So lots of our people they may not have died from COVID, and I think that's testament to how well looked after they were by their families, absolutely determined to make sure that they were removed from as much harm as possible. But within their family homes, they couldn't do that because there was nobody to help, to support them. And I'm sure Jenny will confirm that people have lost their lives because of that, because of, many of them have a scoliosis. That scoliosis can move if it's not cared for and treated properly, if they don't have the appropriate wheelchair. It impacts on their internal organs, which eventually are impacted so much that they can't survive. And so that journey, that was the start of COVID, was the start of that journey for many families. Many families are still on that journey now.
And I think the surprise was the fact that, I mean, we understood it was a unique situation, but it was the fact that everybody walked away. I mean, I am an allied health profession, and I had discussions with somebody at the government who I mean, why did the allied health professions not stand up and say, actually, we need to carry on seeing these young people? Because their support usually was, for young people, was in the schools, or for older people, it was in their resource centres. And suddenly there was nothing there, and the families were being expected to do it all. But we know, how important that was for them, but everybody disappeared and they were sent. Obviously there were other priority areas, but actually, again, that invisibility that we weren't seen as a priority has had such a huge detrimental impact. And for some families, it wasn't just their loved one with a profound learning disability, it was also the siblings that they were trying to school, they were also trying to work from home. It became a really difficult time, and nobody knew how long that was going to last. I remember people thinking, well, okay, we'll get on with it. But it went on and on and on, and we're all in it together, and we promise that things will get better. And actually, even post-COVID, we had an assurance from the minister that things would get better and that they would get services. But here we are, further down the line, and people still haven't got back to where they were pre-COVID. That group of family carers are still out, alone and managing, and when you haven't slept for 4 years, probably for some of them.
Stephen, I hope I'm not going to say something or interrupt you. You may be coming to what I'm about to suggest, and if you are, I apologise. Stop me. But all the things you just described, I would have thought might have been anticipated.
You would have thought.
Yes.
Yes.
Do I take it from that answer that your organisation, for example, weren't asked to contribute to a thought process that might have outlined the possibilities in the event of an emergency such as a pandemic arising of this?
No, we weren't ever asked about that. We were asked as we went along, and we made a lot of particularly early contributions about what we felt should be happening, and we did speak very vocally about the fact that there'd been a withdrawal of services. But I suppose that, and I mean, yeah, I'm supposed not to reflect, but I keep asking myself, what was it that we didn't do that meant that our voices weren't heard? Because in the early days, we were on, almost on a daily basis, talking to civil servants in the government, feeling that you'd been heard. But as other organisations, I mean, we were small, so we were able to do things very quickly. But as other larger organisations came on board, I felt we were drowned out, and that group wasn't listened to, and it wasn't heard, and those families were absolutely desperate, and there was just no. We weren't asked about.
You weren't asked. And there doesn't appear to have been any planning.
No.
I'm sorry if I.
Not at all, my Lord.
You may have been able to cover that in any event.
No.
It's a very useful point, though, for what we would like in the future, actually, to be part of that. Well, we want families to be part of that planning process. Because, sorry, I'm going to jump in, but the other thing is these families are absolute experts in infection control. I mean, when we started talking about how we would move out, we went to the families and said, this is our risk assessment, this is what we're thinking, can you give us some advice? Because every day from the moment they're child is born, they are thinking about how to minimise the risk of infection control. And we kept saying, come and talk to this set of families who have infection control. Absolutely, you know, their kids are alive because they've done it so well, but nobody ever came and asked. We did.
Well, yeah, we did. But I think it comes back to, we've mentioned invisibility, and I think that what this talks to is a real lack of understanding and a lack of will to understand what distinguishes people with PMLD from others. And I suspect, and I may be wrong about this, and I may be wrong to be hazarding a guess, but I wonder if there was such a fundamental misunderstanding that our group was lumped in with care homes and were treated in the same, well, we know we were treated in the same way as care homes, but that's to fail to understand and I guess I'm talking about adults here, but that's to fail to understand the distinction between an adult with PMLD and somebody who would be in a care home. Most of our people who live in supported accommodation of whatever description live in homes of their own with their own tenancy in small groups, either single tenancies, 1 or 2, 3, usually no more than 4. And so they were essentially treated in the same way as care homes. It's a fundamentally different type of organisation, and they should have been treated as if they were in their own homes. It took a very, very long time for that to filter through. And in the meantime, lots of people who were looking after, or whose son or daughter was being looked after in a supported accommodation, didn't get to see their families for many, many, many months, sometimes as much as 18 months, well, not in any meaningful way. And that was because they were being treated as living in care homes. But it just reinforces our view about our group being invisible, that they weren't treated in the way that they should have.
But you talk about invisibility, and I understand you're using it in a particular sense, but your group, PAMIS, has been on the go for, you've told us already, a long time. And I'm assuming, and I think it's inferential from what you've already said, that you talked to government long before COVID. You talked to government and tried to, no doubt, educate them long before COVID, and therefore there should have been an awareness at government level of the existence of this cohort of persons that suffer from these issues and their needs. Am I correct?
And yes, and I think...
And you were presumably on a fairly regular basis bringing forward this thing, and therefore one can argue, I would have thought, that there should have been some anticipation that in the event of a pandemic, these people would have exactly the sort of problems that you would have if there was a withdrawal of, I think you said, in the blink of an eye, everything went. The framework vanished overnight. It should have been thought about.
Yes.
Is that a reasonable? It's just a proposition I'm making. I want to be clear, but is that a reasonable proposition?
Yes, it is.
And I think from our perspective, there was a group in government that understood, but it was how that group were then able to influence. And I suppose, one of the things that, people, you seek to understand, that you sometimes think but that's the bit about the communities, don't really understand how to include. I think that there was a wider government group that thought they knew who this group were, but actually didn't. And our ask is, if you're really not sure, ask all those questions. Watch that film, make sure that you know who you're talking about, because I think what we felt was that there was a small influence within government, but that actually then trying to broaden that out, and the people that were making the decisions, just didn't understand that there was this subgroup. I mean, even a subgroup within a subgroup, people with learning disabilities are often marginalised, but this group are a totally separate group within that group.
And I think what was ironic was that there was a lot of mention at that time about how we should be protecting, or how we were protecting, the most vulnerable members of our society, without any apparent understanding that this group is the most vulnerable group in society. And were totally sidelined.
Yes, but remember, one of the purposes of this inquiry is that at some stage, Mr. Stevens or one of his colleagues might well be asking someone who represents government, what about the profound multiple difficulties, and
Yeah,
why
good.
did you not anticipate in advance? Is that not one
Yes.
of the things that we could legitimately ask?
Yes.
Definitely. Yes.
I'm sure Mr. Stevens will make a note of that.
I have. Thank you, my lord. Jenny, you said government on a couple of occasions. I just want to be crystal clear. Were you talking about the Scottish Government when you were talking about
The Scottish Government,
Just to be clear.
there's a group of civil servants within there that work on the learning disability portfolio that we were in immediate contact with when the pandemic happened.
Fine. And Pat, since you raised it, we'll come to it, the supported accommodation point,
Yeah.
because I wanted to ask you about the impact on the families, I suppose. You talked about people being isolated, kept away, and because the two common settings I think you both described for where people with PMLD would be a family at home,
Yes.
or in supported accommodation. You've talked about the latter. What were families' reactions to that situation where, as you've described today, intimately involved in the care of their loved ones and they're unable to see them? What was the reaction that PAMIS was getting from families? What did they say about this?
I mean, they were really angry, weren't they? Because, I mean, one of the key things is, and one of the papers that we wrote was that they weren't just visiting and seeing their loved one there. They actually took part in sometimes very personal care, so that they were frontline carers, and they were providing that emotional support as well, and providing activities. And I remember one mum talking about the fact actually it wasn't about getting in, it was about getting people out as well, because they were needing to get out about, being able to be part of their community. And I know that for some people really, well, for you, really broke down. But it wasn't just being, and I think it was absolute desperation, as people got urinary tract infections, because some of these very personal care issues weren't being carried out in the same way as a family carer did. And I know we had a little subgroup, and people were very angry because they just didn't feel that they were being heard.
Yeah. I think it was. I maybe think at the start we thought, oh well, that's a reasonable thing to do. A couple of weeks, that'll be fine. We'll get back to normal. I mean, my personal circumstances are that my daughter comes home to our house 3 times a week for half a day at a time to visit, and we take her out, and I'm very actively, as Jenny said, very actively involved in the provision of her care, and consider myself to be part of the care team in my daughter's house, and would be considered to be part of that care team by the staff in the house. And that's my circumstances, but that would be reflected across the country with probably, well, many families anyway, that we do a huge amount to support the staff. And of course at that time we were no longer able to provide that support. I mean, apart from the fact that obviously we missed our children, but we were no longer able to provide that support to the care provider, who were on their knees and needed all the help that they could get, and we couldn't do that. But also because they were on their knees because of COVID, they weren't able to provide, despite their best efforts, they weren't able to provide that same level of support to the people that they were caring for, because they were so busy sanitising and cleaning and doing all the things that they had to try to find PPE. And I do remember in the early days of the pandemic spending a lot of my time online trying to source various things like soap and gloves and potatoes at one point, the things that they couldn't get, and then driving them up there and dropping them on the doorstep, taking things up for my daughter and the other people that live in our house as treats, just to try and feel that I was still doing something to help. But in all that time, my daughter her health was deteriorating significantly, physically and mentally, emotionally, and cognitively as well. But she was tilting over to the side. I've seen photographs of her at that time. She just withdrew into herself, and eventually our care provider decided that her emotional state was such that she had to be allowed to come back to visit us in the family home. And the guidance, I think that was about 3 months in, the guidance changed at that time enough for them to interpret it in that way. However, I guess it was 3 long months before we saw her again, because she didn't want to interact with FaceTime or Skype or any of these things. But for many other families that PAMIS was representing, as Jenny mentioned, that wasn't the case, and many care providers interpreted the guidance in different ways, and which meant that families were still, a year later, still seeing their family member through a window or, on Skype or something like that, whatever, in a garden, in a gazebo, because of the interpretation of the guidance. And I don't know, if my daughter's care provider could interpret it in a way that meant that we could see her, we couldn't quite understand why others didn't. And we were trying to support families in that and provide them with copies of risk assessments that my daughter's care provider had provided to ensure that her safety. My daughter recovered emotionally, I think. Physically, she won't ever fully recover. She says she has to go to a chiropractor regularly and probably will do for the rest of her life because of the damage of the not moving and inactivity over that 3-month period. Many others will be in the same position.
To ask you if there's a lesson learned there, in your view at least, when you have that piece of the puzzle of the families that is being taken out of the equation. You've talked about the strain on the paid carers who were there. And this inquiry has heard before, I think, evidence about, for example, Anne's Law.
Yes.
Is there a lesson learned, would you say, in what happened here with supported accommodation?
Yes, there definitely is. It would have been, and I think Jenny alluded to this earlier, in terms of the care that families take of their family member. Essentially, we, in many cases, have kept them alive for a long time. I mean, that's a responsibility that we take, every family would, but we take that very, very seriously. There would have been no reduction in that commitment to our family member because of COVID. In fact, the opposite was true. We were not going out, we weren't doing anything. My partner and I were staying in the house, we were having our hours walk in the park. We weren't meeting up with anybody. But staff, by the very nature, go home to their own families. And so the staff were a much higher risk to our family members than we were. And there was no recognition of that at all. So I guess what we would want is much the same way as the in Anne's Law, that we would want to be designated key workers, because that's what we were. It would have made it easier for everybody. It would have saved a lot of heartbreak for a lot of families. But also it would have made the lives of paid carers so much easier and so much more effective as well.
I think one of the other lessons is about being really clear about how to carry out a risk assessment. The guidance said, you look at the risk about emotional deterioration and physical deterioration versus the risk of COVID. And what we were finding time and time again was that somebody one organisation could do that. We were sharing all that information. But we even had in one local authority where one of the family support directors took that risk assessment, worked with somebody from public health who agreed it was really important to go in and see somebody and to have that time. And then the next day, when they phoned again to confirm it, it was somebody else, I'm sorry, it was from public health, but somebody else from public health said, no, that isn't how we do it. So nobody was carrying out the risk assessments in the same way, and actually nobody was looking at the risk of the emotional and the physical deterioration of individuals versus that risk of COVID. I understand it was a difficult time, but the lessons I think we would like to be learned is how you collectively involve everybody in looking at carrying out a full risk assessment. And the risk assessment that came home from the organisation, you added to it, and then it became a very comprehensive piece of work. And sorry.
And you've touched on the physical impact, postural deterioration being key amongst it, and a little bit on mental health. What would you say has been the impact, if any, on the families in terms of mental health? What messages have you had from families?
Oh, goodness.
Yeah, it is, and it's still, ongoing. It was really interesting. I was just reading over somebody's statement. We had a counselling service And in the height of COVID, actually, families, I don't think, could even begin to think about what was happening to themselves. So actually, numbers of going to the counselling really dropped. But as we began to come out of lockdown, the numbers began to increase. But that impact was awful. People were exhausted. I think, to start with, people felt that everybody was working together. But then as time moved on, I think that whole issue about not getting access and not understanding about how to get access to your loved one in supported accommodation became an enormous issue. And people became incredibly depressed. They're then, not having any support, no respite, not having... we did also have cases where there was clear guidance that said nobody's care packages were to be looked at, but I remember, a mum who became incredibly depressed and lost all hope because somebody was threatening to take away what little care package she had or to reduce it. And I think I shared that. that was a very dark day because she talked about a suicide pact, because she just couldn't see a way out of it. So it became a really, really difficult time, didn't it?
Yeah.
Oh, it still is, I think.
Yeah, it still is. And I think also, without a pandemic being in existence, people who have family members with PMLD tend to have difficulties with emotional well-being anyway, because life is very, very difficult, very challenging. And I guess most of us try to have a very positive outlook, because if you had too negative outlook, you probably wouldn't survive. And Jenny alluded to suicide pacts, and that's something that isn't. It might sound shocking when you say it out loud, but actually it's not that surprising and it's not that uncommon, because life can be so difficult and so challenging. And you add a pandemic into the mix, everything is taken away. All the things that make your life viable, make it possible for you to work, to spend time with other family members, to go out and do the odd thing, to have the occasional weekend away or whatever. All of that was taken away, and those are the sort of the little lights at the end of the tunnel that actually make life worth living when you're under that sort of stress. And then to have all of that taken away, I don't know why we didn't have more families where there were much more tragic outcomes. And I think, well, actually, I do know why that is. The reason for that is because if you decide that you can't take it anymore, you're leaving behind somebody who is even more vulnerable than you are, or you have to take them with you.
I think physical well-being was another issue, and we picked that up on some of the webinars we were running on moving and handling, because suddenly you were doing all that physical activity without necessarily the equipment. So we noticed, and people were putting on weight, so their relative increased in size, or because they were a child and they're going through adolescence, they grew. So we noticed also, there was that physical decline of carers' well-being as well.
But also cognitive decline, because if somebody has a profound learning disability, it takes them a long time to learn things. And actually that's one of the things that families do really well, is to teach people with a profound learning disability to the level of their ability. But sometimes those things can take a very, very long time for them to learn, but it takes a much shorter time to unlearn them when you're completely unstimulated, not able to do anything, not able to move. And actually a lot of those skills that they had acquired at great cost to families and great effort will have been lost for all time. And that's really, really, really sad, when you've put so much effort into ensuring that your child has the best life that they can have. To lose that is devastating.
Jenny, you mentioned webinars, and I'd be remiss when listening to your evidence not to ask you about what PAMIS was trying to do to help these poor families that seem to be going through a very dark time, as you put it. I'm interested in particularly webinars, but also I think the digital passport is something that caught my eye. Would you mind explaining what that is?
Yes, I mean, very quickly we became very techie savvy, which was quite amazing for some of us. But that whole ability to be able to actually reach out to families, and because we have a practice development arm, some of our multisensory activities we were able to then put online. So very, very quickly we developed an online program which brought family carers together. Actually, it brought people with PMLD. We took a lot of advice from experts because we were really worried about whether somebody with a profound learning disability would be able to interact, via Zoom. But it was quite dramatic and quite amazing. I mean, this lovely music instructor that we worked with actually found that in some ways it was more effective using Zoom than it had been. So we began to develop a lot of resources online for families, for people with PMLD, but also for those paid carers. But I think almost overnight
unpaid carers
and unpaid, paid and unpaid carers. We developed some of our postural care resources. I mean, that was quite interesting because suddenly postural care becomes everybody's business, because actually when you have COVID, you're needing to be in the right position. So a postural care strategy that we'd been pushing for years probably was sped forward by about 5 years because everybody needed to know about postural care, not just our group. So we managed to convert some of the education materials that we had for both practitioners, but again for families online. And we worked with NHS Education for Scotland to do that. Moving and handling was coming through the family support as a real issue, and so we worked with this fabulous consultant that we'd worked with for years, and he ran with us some sessions for families where they could bring their issues, and what we were finding was people were being sent pieces of equipment without being measured for them, and so he was really good at helping people risk assess before they were using that equipment. But it was a brilliant way of bringing families together. I mean, some of the webinars, we actually had people from across the country, coming, and it was a way of sharing. And then families, again, I was reading a member of staff statement. We were really flexible about how our family support directors worked, and for a lot of them, actually being able to work in the evening was good for them, but it also helped the families. And they used to have these fabulous family chats, just a time, often 9 o'clock at night when people had managed to get their loved one to bed, and then they would come and support each other, but also we would share the latest, what we thought was the latest advice. We'd talk about some of the issues that were coming back. They would feed into me so that I could feed up to the government some of the things that they were talking about. And on a Friday night, we used to have a Friday night virtual disco, which was the most, and it still is one of the most popular pieces. The digital passport was something that we had developed. It had been developed by family carers. It's a communication passport that used to be paper, and one day a family carer said that would be really helpful if it was a digital one. So it's using PowerPoint, and it's a flick-through ebook, but it tells you all about the individual, and it's written normally in the individual's voice so that they can tell you the things that they like to do, the way they like to be positioned, being able to show how to put somebody in the right position for their postural care through video and photographs is so much easier than writing it down. And I think what we were finding was it became more and more useful as paid carers started coming back, because it often wasn't the paid carers that they had before, but it was a way of very rapidly being able to give people ideas about how to care, but also how to engage with someone. And we made a decision that actually they would be free of charge, and we would provide training to any care group that wanted those, because we just felt it was a really, really useful tool. But it also gave people, the opportunity to show who that individual was, what they liked doing, who their friends were.
And the feedback from families was positive on these initiatives?
Yes. I mean, I think lots of families said it was a lifeline, actually, having activities and having something positive to do. And we had we did the Edinburgh Book Festival virtually, actually, and there was lovely collaboration with the music group and the art group, and even doing online art sessions. Actually, I mean, they've carried on. And the lovely bit about that was we were making connections across across the whole of Scotland. So, you know, suddenly there was somebody in Fife who became really good friends with somebody in Lanarkshire, and, you know, I mean, it was really lovely when they all met together when we were able to go to the book festival actually in person. But yeah, there was a real sense of our community, I suppose, coming together.
I wanted to, I suppose, well, finish before giving you an opportunity, as I said. How would you sum up, I suppose, a longer-term impact of the pandemic upon the community, as you put it, of PMLD? I mean, what effects or signs are you perhaps seeing or not seeing even now?
Yeah, so it has had a dramatic impact, I think. I mean, you know, postural care is again, it was led by a family carer a number of years ago, 16 years ago. It's a very, very important way of thinking about how to keep somebody's positioning and their posture safe so that they don't develop scoliosis. I mean, I was told the other day that somebody died of cerebral palsy. Well, no, you don't die of cerebral palsy, and you certainly don't die of cerebral palsy if you put the right interventions. Those interventions didn't happen because they didn't have the right input from healthcare practitioners, really. And so there are now definitely, you know, the impact. People will die earlier because they haven't had that intervention. Some people now aren't able to have the spinal surgery that they would have been able to have. And so that physical well-being will have a lasting impact. I mean, we said we were very lucky that not that many people died of COVID, but a lot of people will die because of COVID. Emotionally, and you know, there will be some people, I know, that they feel that they've almost lost their loved one because they had so little social interaction, and that all those skills that Pat talked about that took years to develop might never come back. People have lost the communication skills that they had. I think for some families, they feel that their loved one in that supported accommodation has forgotten them, and that relationship isn't there anymore. And for families, sorry, Pat, I'll let you get in a minute, but for families, you know, that whole exhaustion, invisible, not valued, you know, that loss of hope, really, you know, it's really difficult. And I know at the moment, you know, we're trying to engage in all sorts of consultations about government strategy, and I'm getting a real sense people are thinking, well, what's the point, you know, when we were so forgotten in a pandemic, when we were all supposed to be here together, you know, what hope have we got anywhere else, really? So there's definitely, when we're not out of it, we still don't have people back at day services. You know, was that an opportunity to close something down, or was it an opportunity to really think about how to do things differently? Families are really sceptical about that because at the moment, you know, they're being told, you know, your relative can't go back to day services. So, yeah, it's pretty dire. It's still pretty dire.
Yeah. I think it's the trauma of what happened, and what continues to be the case for lots of families, is something that people will take a long time, if ever, to get over. It's a sort of PTSD without the post. It's a kind of continuing, you know, ongoing stress that people have. And I think, you know, we talk about long COVID meaning something different, but I think for our families it is a form of long COVID because it's something that they're not going to get over. You know, whether it's physically or emotionally or mentally, whatever it might be, it's going to be long COVID for them for a very long time to come.
Well, I'm very grateful to you both. I don't have any further questions to ask you. As I said at the outset, the inquiry is grateful for everything you provided, the statements, the documentation, the video, and of course your oral evidence today. So thank you very much.
Thank you.
Yes, and I'd just like to echo that. Thank you both very much for your attendance. I'm very grateful.
Could I add one thing about the impact, though, which we haven't spoken about, but I know there is a statement, is that impact, if you had a child, if you had a baby, I mean, I had a daughter who had a baby during COVID, that was difficult enough, but I think there needs to be a lot of thought put into if you had a baby with a profound disability or complex disability during COVID. You know, I know one member of staff worked quite closely with that group. That is something that we need to be thinking about how we're supporting that group, because you know, that the initial support that you might need wasn't there. So I think they're a group that we worry about, and I suddenly realised we hadn't mentioned them at all.
Is there anything else you'd like to add, Pat? Before we...
Well, yes, there was one thing I wanted to. Because we've been, you know, we've spent months now writing these statements and speaking to people and reading our staff statements and other family statements and so forth. And I was trying to think, what if I had to sum up what I wanted to say about it, I hadn't been able to say anything at all today. If I hadn't been able to give a statement, I wrote down what I would have wanted to say, and would it be okay to just read that? It would take a minute, less than that. It's important to emphasise that people with PMLD cope with all the disadvantages in their lives with bravery and stoicism, and still have the capacity to not only derive pleasure and to fulfil their potential, but also to bring joy, inspiration and love to those who have the privilege of knowing them. It's so important to understand that people with PMLD can still have a quality of life, because if you don't understand this, then you can't possibly comprehend the scale and impact of what was taken away from them. Because they couldn't comprehend what was happening to them, many experienced sadness and anxiety, fear and emotional trauma, in addition to their physical pain and discomfort. And as so many have no spoken language, they were unable to tell anyone how they were feeling. It's difficult to imagine how that must have felt. And these are precious people whom we should be valuing and nurturing, but we failed as a society to keep them safe, and tragically, we let them down. Somewhere along the line, in our fear and our panic, we managed to lose our humanity too, and we need to make sure that we learn that lesson for the future.
Thank you for that.
Very good. Thank you again. Good.
Thank you.
We'll come back about 20 past, something like that. Thank you very much indeed. Now, good morning, Mr. Gale, this time.
Good morning, my lord. Yes, the next witness, my lord, is Jane Ormerod. Her witness statement is SCIWT 0456, and then 50 is worn.
Good. Now, good morning, Mrs. Ormerod.
Good morning.
Good morning, Mrs. Ormerod. Your full name is Jane Ormerod, I think.
Yes,
And your personal details and your contact details are known to the inquiry, and you provided us with a detailed statement, which I've just given the reference to. And that statement, to aid you, will appear on the screen in front of you, but I think you've also got your own written hard copy of it. And you are content, as I understand it, that that statement, together with the amplification of it that you'll give in your oral evidence today, will constitute your evidence to the inquiry.
I am.
And you're agreeable that the evidence shall be published and recorded.
I am.
Thank you. Now, as will be apparent from your statement, you are here to speak as the current chair of Long COVID Scotland.
That's correct.
And that's a position you've held for about 2 years.
Yes, that's right.
Yeah. And I think it's quite a busy day for you today, because I think there's to be a debate in Parliament this afternoon or this evening, and I think you're anxious that you're able to attend that later today. Importantly, I think you are able to give evidence to the inquiry, having had a nursing background. Could you just explain a little bit about that background, please?
Yeah, I spent 40 years plus in the health service. My professional registration was as a nurse, and I worked clinically in cardiac care and cardiothoracics for quite a few years. I was a clinical teacher, clinical educator, and in the latter part of my career I worked in professional development and practice development.
And has that background assisted you in the work that you've carried out as the chair of Long COVID Scotland?
To some extent, yes. I worked in several leadership roles, so that's not unfamiliar to me, although not in the third sector. But working in the health service for all that time, and then working in the third sector and in a different context, it's not always been easy, actually, and continues to not always be easy, having had a health background. It's very hard to explain. It's working in health is a bit like an inclusive club, and working on the other side of the fence as a patient advocate and patient representative is very different.
Yes.
So it's been a learning exercise and continues to be.
But as I think is apparent from your statement, you are now really quite wholly committed to your role as the chair of Long COVID Scotland. I've
been very fortunate. Long COVID Scotland are an advocacy organisation, a charity now. We became a charity in 2022.
Yes.
And I'm in the privileged position of being in the chair. There are, at the moment, 7 of us as trustees. We are a small organisation. We all have long COVID. All our volunteers at the moment, apart from one, have long COVID. We're not a cast of thousands, they're a small group, but we work hard to advocate for people with long COVID in terms of more effective diagnosis, treatment, support and rehabilitation.
Thank you. Now, you have very helpfully provided the inquiry with a number of documents, all of which are footnoted in your statement. And we will look at some of the results that you have obtained from the surveys that you've carried out as we go through your evidence. But you are also content that the inquiry has regard to these documents, which it will,
Yes.
as we progress with our consideration. Is that right?
Yes.
You've said that you have long COVID. I don't wish to pry into that unless you are agreeable to doing so and providing us with information about that. But if you are, can you tell us how you contracted COVID, when you contracted it, and your subsequent diagnosis with long COVID?
Yes, it's 4 years since I originally had COVID, and I think it was probably going to the theatre that did me, and I developed COVID. Of course, testing wasn't available at that point, so it was a diagnosis of exclusion, really. To begin with, I was not hospitalised. I felt particularly unwell, though. I had a lot of tachycardia, breathlessness, fluctuating temperature. I did go to the COVID hub in Aberdeen, where I live, and I was just sent home just to recover, as they put it. And unfortunately, my symptoms carried on fluctuating over the next few months, and I struggled considerably. I developed a sore throat that lasted for 6 months. I wasn't to know it, that was a re-emergence of a Epstein-Barr virus, glandular fever. I didn't even know I'd had glandular fever in the past, but that came out of the woodwork for me, and I felt even more ill with that on top of the COVID. I was diagnosed with long COVID in June of 2020. Getting that diagnosis was particularly hard. Accessing my GP was particularly hard, and at that period and after that, I was dismissed really as having COVID. I was told I was anxious, it was all in my head, and that it would just go away, that I would recover. Well, unfortunately I didn't, and I saw one GP who diagnosed me with long COVID, and so that started me on a fluctuation and a journey that I've had over the last 4 years. I had COVID again in 2022, and that just made my long COVID worse. I think the hardest thing is the fluctuation of symptoms. I'm unfortunately, and I still suffer with post-exertional malaise, which is any activity that I do, not just physical, whether it's mental, any activity that any of us do, I have a kickback for that. I'll spend time in bed after that. It's very much akin to how people with chronic fatigue symptoms, and just the same as somebody with chronic fatigue, many people have been dismissed for many years. I think one of the hardest things with long COVID is the dismissal by some people that it exists.
Yes. You do tell us in paragraph 4 of your statement, and you've repeated it this morning, that you felt dismissed and minimised by GPs. Could you just give some context to that, please? What were you told?
I was told that it was anxiety. I was told that my symptoms would go away, that I was being over-anxious, overly concerned with my health. Actually, accessing a GP at that point was very difficult. I had some health problems that I'd had prior to having COVID, which resurfaced again during COVID. And prior to COVID, I was waiting for a hospital appointment. And as my symptoms became worse, I tried to get the GP to refer me back to the hospital, which that took a considerable effort. And eventually, I was, after much effort, I was referred back to the hospital, but that took another year for that problem to be addressed. And I think the hardest thing really around the minimisation is there's a fluctuation in symptoms. Very often people struggle to express themselves because for me as well, in terms of brain fog, as people call it, it affects your thinking and your ability to marshal thoughts together. So trying to actually represent yourself in normal terms would be bad enough, but when you're struggling to get appointments with GPs, get seen, get heard, that adds to your anxiety.
On the question of anxiety, which you've mentioned, did you have a history of anxiety prior to being infected with COVID?
No, not at all. As with anybody, the normal fluctuations of day-to-day life can push you to the edge of anxiety sometimes and further. But no, I didn't. I didn't have any mental health issues before that, and I found myself going steadily downhill because of the fluctuating nature of long COVID, the symptoms coming and going, not being listened to, being minimised. I think not only by health professionals but by other people, even family, weren't really sure what was going on and wanted you to be better. And so I felt my symptoms were minimised to some extent by friends and family as well as by health professionals. But I think that was all part of the anxiety that you felt and the whole results of having an illness that just doesn't go away and becomes a chronic illness, and learning to cope with that.
One of the points, again, you've made, you're talking about fluctuating condition. I think in your statement you also make reference to relapsing and remitting, using those two terms synonymously. Is that one of the difficulties that those who suffer from long COVID, and I think we see that have information that many do, that there can be, put crudely, there can be good days and bad days?
Oh, absolutely. I could have a couple of good days in a week and I think, oh, perhaps it's going to go away, or perhaps it's receded into the background for a period of time, and I'll perhaps do a bit more. I'll press myself to do more, just normal activities, and then I will have a kickback from that. I will feel ill, unwell. I'll feel as though I've got the flu. I'll feel cold, feel hot, feel sick, have to go to bed. because I feel too tired to carry on with what I have to do in the day.
I think it probably goes without saying that that is going to have a considerable impact on your day-to-day life.
Absolutely. I think for any of us with that sort of a picture, and not everybody has that picture, not everybody has post-exertional malaise, but if you have something that comes and goes, and if you're in a relationship with somebody, they have to cope with that. If you have kids, and many of our members are in the age group, it predominantly tends to impact on women, although not exclusively so. They're in the age group of 35 to 60, 55, 60. They have jobs. They have to hold employment together. They have a home to hold together. So it's not surprising that it impacts on their relationship with their partner, with their kids, with the wider family, who struggle to understand what's going on.
And again, because of the age demographic that you've referred to, there is obviously, and we'll come to this in a little more detail as you're giving evidence, but there's obviously an impact on the person's ability to work.
Absolutely. I think we have a good proportion of members who are not able to work anymore as a result of having long COVID. It really does depend on the type of employment that they do. It depends on if they have an employer that is sympathetic, who understands about long COVID, and to be honest, the knowledge of long COVID amongst the wider population is not good. People think you just get a bit tired, and that's it. They don't understand that it impacts on your whole life. And from the work point of view, if you are trying to go to work, most people who try to go to work, the only way that they can do that is to do a period of work and then go to bed when they get home. That enables them to hold the job down. If they can't hold their job down, then we do have members who've lost their jobs, who can't pay their mortgage, have had to give up their house. We have quite a few members who work in the health service, and as you can imagine, trying to work in a clinical capacity, 12-hour shifts, with long COVID, it just doesn't fit.
Well, I think I should indicate to you, Mrs. Ormerod, that in the course of the next few weeks, we are going to be hearing from a number of organisations representing healthcare workers, and one of the issues that will be raised in their evidence will be that relating to long COVID. So we will be hearing it from specific witnesses in those areas. You've obviously put a great deal of work into preparing your statement, for which we are very grateful, and you've come here today to give evidence. Given your condition, has that been a bit of an ordeal for you?
Yeah. Just travelling to Edinburgh, well, getting prepared and travelling to Edinburgh, delivering statement today, being here. Yes, I'll have a considerable kickback from today, and yes.
Oh, thank you. You say that your experience resonates with many of the members within Long COVID Scotland. So do you gain any comfort from knowing that you're not alone?
I've made many new friends and colleagues from working in Long COVID Scotland. It's useful. You have a point of contact and a fount of knowledge, really, because people with lived experience are the experts about their condition. So it's useful to be with other people, although, to be honest, many of those people I've only ever met online in a virtual environment. It's only this year that I've started to meet people in a face-to-face capacity. So we've conducted our business virtually until this year, probably.
Do I take it from your position as chair of Long COVID Scotland, and with your background, that you've gained and carried out a lot of work and acquired a lot of information about long COVID as you progressed?
Oh, without a doubt. I mean, one of the benefits of being in the group, as I've said, is meeting other people, but we've also networked and continue to network with other groups nationally. There's a bigger English long COVID support group, there's a Welsh group, an Irish group, and internationally as well we network, and I wouldn't say we meet regularly internationally, but we keep in contact. I mean, I'm doing a presentation next week to an American group at the request of them, with another colleague as well, because they want to know what's happening in Scotland, and so we share our information. We don't hesitate to ask if we need any help from other groups.
With that amount of research that you've done and information that you've acquired, just one thing that occurred, I think, from the outset of the representation of long COVID groups in this inquiry, is consideration of whether long COVID could have been predicted. Do you have a view on that?
I think, given the existence for many years of other post-viral conditions, such as ME, CFS, Epstein-Barr, they've been well known about for many years, how they arise. I wouldn't say that they're well treated, and the people that have those illnesses have been subjected to the same sorts of things that we have as well.
When you say the same sorts of things, is that range from general skepticism to outright antagonism?
Absolutely, yes. I think that hits the nail on the head. And, you know, in terms of that, then it should have been predicted that infection with the COVID virus, SARS-CoV-2, we should have been able to predict that something like this would happen. And, you know, pandemic preparations surely will have been rehearsed, and that may have been included in that rehearsal. So why would we not better prepared?
Right. Can I just ask you a little bit about Long COVID Scotland, its structures and its aims? We can read about these in your statement, and I'm not going to go through it in great detail, but You're a volunteer-led charity, as I understand it. And I think you mentioned that since September 2022, you've been a registered charity.
Yes.
Do you receive funding from anyone?
No. No, we don't receive funding.
And you've explained the structure of your group and your membership, and we can read about that. One of the things you've mentioned is that you seek to advocate to get your voice heard by the Scottish Government. And you've worked to establish partnerships with various organisations, including the Scottish Government, also the Health and Social Care Alliance Scotland, Chest, Heart and Stroke, and various researchers from universities. That's in paragraph 14 of your statement. Can I just ask you a little bit about your relationship, particularly your relationship within the terms, within the time scale that this inquiry is confined to, which is to the end of 2022. Mm-hmm. Ask you a little bit about your relationship with the Scottish Government.
Mm-hmm. It has always been a struggle getting heard, recognised, accepted, I think, as a serious group, and not just a virtual group, a Facebook group, but as a recognised group advocating for people with illness.
And you're on the other side of that. What's your impression as to why it's been a struggle?
I think there is perhaps a view that people with illness should be heard, but only so much, and kept in a place, not treated as equals. I mean, we would look to have services developed in a co-productive way. We are looking to work as equals to inform the development of any service that might involve patients with long COVID. Actually, whilst Scottish Government might say that they work in that sort of a way, in a co-productive sense, and I know there's a whole dimension of co-production, from patients at one end working as total equals to health professionals or researchers or whatever, and then at the other end, patients it's a tokenistic thing. And I think we are somewhere, perhaps not even in the middle of that. And I think that's because it's quite hard to do that, to work in a true co-productive sense. It means that more effort has to be made to hear what patients have to say. More effort has to be made to include them in all meetings, in discussions about service development, in actual developing a service. It is quite hard to do. It's not impossible, but it is quite hard to do, and it requires a change, I think, in attitude and culture, which I'm not sure that Scottish Government are willing to go the whole hog with that.
Obviously, I've prefaced what I asked you by confining matters to the period of our remit in this inquiry. I think I have to ask you, have things improved since?
A little, and I say glacially slow, in the sense that there is a long COVID strategy network, which was established in 2022, I think, if I'm correct, 22, And there is a lived experience group within that network. When it was first established, there were only 2 of us with lived experience on that group. It's a lived experience group. There were only 2 of us with long COVID. Myself and Helen Goss were both on that group. Unfortunately, the numbers of people on that group with long COVID haven't increased. In fact, they've decreased. There's only me at the moment. So within the long COVID strategy network, there is only, I think there's myself, and there are a couple of professionals now with long COVID that have come into the strategy network.
Who else is on that strategy network?
They are professionals from the health boards, from Scottish Government, project managers from Scottish Government. It's a range of people who are working to deliver on what the network, the strategy network, is hoping to achieve, and that's the establishment of services in the health boards.
Do you feel that it would be either necessary or appropriate for there to be a greater voice of sufferers on that network?
Oh, without a doubt. I mean, I've been arguing for that for the last 2 years, looking for a panel, a patient panel to be established. Communications are not good. The flow of communication back and forth from the network to the boards, from the boards to the network to patients, it's not satisfactory. Patients don't know what is going on. And I am just one person. I can't communicate with everybody.
You mention in paragraph 16 of your statement a long COVID summit, which occurred in 2021. Can you tell us a little about that, please?
Yeah. We hosted a long COVID summit. It brought together a range of people who had an interest in developing services for people with long COVID. Ourselves, Chest, Heart and Stroke, the Healthcare Alliance, Scottish Government, range of patients were involved.
What was its outcome, if I can put it that way?
We produced a mind map of everything that patients were speaking about in terms of what they thought were important to them about developing a service for people with long COVID. And the idea was that that would inform the development of long COVID services moving forward into what was the establishment of the long COVID strategy network.
I think this is what you talk about in paragraph 18 of your statement. And you say that it was an event which we organised feed into discussions with the Scottish Government. Was it of assistance in either initiating or continuing discussions with the Scottish Government?
Both, I think. I can't say that we didn't meet with Scottish Government. In those early days, actually, we had more regular meetings than we have now with them. And that work informed meetings that we had with Scottish Government about how we could inform the development of services.
Yeah. And you obviously would have at that point, and presumably it continues on, having views as to the level of care and services that are necessary?
Oh, without a doubt. I mean, from the beginning of this work up until the present day, people with long COVID have been very clear about what they want, and they want long COVID informed services.
And put simply, is that what is happening?
No, not in its entirety.
Where are the deficiencies?
The deficiencies are around accessibility, equality, accepting that Scotland, health boards are in different bits of Scotland, and what fits in one health board might not fit in the other in terms of geography and access. However, we have always maintained that there should be some core tenets to the provision of a long COVID service, a multidisciplinary, the availability of a multidisciplinary pathway that people can access, a clear system for diagnosing and treating long COVID. Now, it's fair to say there are some elements of that available in some health boards, and it's taken 2 years, 3 years to get to the point we're at now, where I think the Minister spoke earlier in the week about how many health boards had a long COVID service in situ, and I think it's all but 2 of the health boards she insisted had services available. We would maintain that what is available is not accessible. It's not meeting the needs of people with long COVID. If it was, why would people still be saying that they can't access services, that they don't meet their needs? People having to go for private care because they cannot access, either through their GP or indeed through any other route, a service that will help and support them.
Sure. One of the points that you make, have already made and continue to make throughout your statement, is the difficulties that you personally and your members have had in being heard, in, first of all, obtaining appropriate diagnosis and thereafter obtaining care and treatment. Have you given thought, I'm sure you have, as to why there has been that difficulty in being heard?
I think, as is often the case, if people don't understand something, or they don't have enough knowledge of what it is that people are seeking either information or help about, for some people it's easier to just dismiss it. And I think particularly for health professionals, for some health professionals anyway, it may be a sign of weakness that they don't know what it is that people are asking them about, whether that's about treatment or a certain drug to do with long COVID. And along the way, I think one of the things that I've had said to me is that I've had a number of things said to me. I think I've alluded to a couple of them already.
Get out and exercise.
That's one. And the other is, well, there's no research on long COVID. We don't know anything about it. Well, we actually do. We know a lot more now than we knew 2 years ago. There are good trials, robust trials that have been done around drugs and treatment.
I think we'll hear from Dr. Taylor this afternoon, and one of the papers that she will refer to is a paper in the Lancet on the efficacy of metformin, which is a diabetes drug, which I think has I've forgotten the precise percentage, but I think it's in the 40% efficacy in treating long COVID. You're aware, obviously, of that.
I am indeed, yes.
You've talked about, perhaps, and I don't want to use this pejoratively, but ignorance on the part of certain members of the medical profession. There is also, obviously, a public perception. You've mentioned friends, possibly family members, who have a particular perception. Does that perception, or has that perception changed over the period since 2020?
For some people it may have. I think, the more information, the more there is in the press, on the TV about long COVID, people speaking about what long COVID means for their lives, then that may influence some people. However, for many people, COVID has gone away. They think it doesn't exist anymore. So therefore, how can you have long COVID if COVID doesn't exist? We don't have any strong public health messaging around COVID or long COVID. We don't have any strong public health messaging around masking, around ventilation. So people just think it doesn't exist.
No. And probably certain of these statements that have emanated from people in power may not have assisted.
Absolutely.
I wondered if you're just completing this section on perhaps touched on a lot of other matters, but on your organisation, if you could just go to paragraph 29 of your statement, and indeed to paragraph 30, and just so that we have for both the inquiry's view and also for public consumption. Could you just read out paragraph 29, because it tells us what your members want.
Our members are very clear about what they want. People with long COVID need to be listened to, and lived experience needs to be at the heart of solutions. We need space and structures to be created so we can inform processes and action. For example, a stakeholder panel.
Thank you. You also mention in paragraph 31 the Scottish Government producing a document, Scotland's Long COVID Service. Can you tell us a little about that, please, and its significance?
We hoped when that document was produced that it would lay the groundwork for the development of services. And in fact, the Scotland's Long COVID Service informed the development of a Long COVID Strategy Network. And we were hopeful that services would be quickly developed in the health boards, that lessons and information around what was happening in the rest of the UK and in England, who were a little bit further ahead than ourselves in terms of developing services, and thus had some idea of what might be worth persisting with and what was working, that we would be informed by that, and it would help with the development of services here. we didn't see a lot of that. There was a reluctance, I would say, of the likelihood of learning being acknowledged and influencing what we were doing here. A little of that got a bit better further down the line, probably more in the last year and a half. But we certainly thought that, okay, services will now be developed in health boards, and we will see patients able to access care and treatment. As part of the network, there was an education strategy, because one of the issues, and we've already spoken about, is education of health professionals, particularly around GPs who were being faced by a lot of people trying to speak to them about long COVID. And we've always had a lot of feedback from our members that amongst the GP population, it was very varied in terms of their knowledge and understanding of long COVID, despite the fact that there were a couple of guidelines, a signed guideline written about long COVID care. Many of them didn't know anything about it. And in fact, our members were taking a copy of that and handing it to their GP so that they would be better informed. And that was only one of a number of things that members were able to hand to GPs. So we were hopeful that the strategy network would inform education of health professionals. We would see services develop. It didn't happen as fast as we hoped it would.
Has it happened at all?
Pardon?
Has it happened at all?
It has happened. Some of it has happened. Money was made available as well, and to be allocated over, we thought it was 3 years, but in fact it's 4, and that ends in 2026. That money was made available for the development of services within health boards. Mm-hmm. Much has been made of that money being spent. And in fact, some of that money hasn't been spent because of the difficulty of engaging staff within health boards. Right. So things happened glacially slowly, and they still happen glacially slowly.
Thank you. Now, you go on to, at paragraph 34 and following of your statement, to give some information about the emergence of long COVID, and we can read what you say there. But in paragraph 34, there's one point I'd like to explore with you. You say that despite the high number of people being hospitalized, and I presume that's with COVID itself, government advisors said there was an expectation that most people would recover, would experience milder symptoms and could expect a full recovery. Are you putting that forward as a criticism of the initial advice, or is it simply a statement and that events that have happened subsequently have cast doubt on that?
I think it's probably a criticism based on, you asked me the question earlier about what we should have known might happen as a result of a virus like this. And there must have been some sort of picture around what might happen, how this would pan out. I'm sure some people would be in hospital, but I think it was very much promoted that the majority of people, if they got COVID, would experience milder symptoms and could expect a full recovery. That was pushed for a long time, and I still think to some extent that is pushed.
That would be a clinical question, wouldn't it?
Yes.
Because you did say earlier on that on the basis of other viral illnesses, there was known to be residual or long-term effects. And therefore, we could no doubt hear evidence from appropriately qualified clinicians as to, A, if that was true. I'm not, for instance, suggesting you're telling untruths, but A, if it was true, B, what the incidence of it was,
yes,
and so forth and so on.
Yeah.
Yeah.
Thank you, my Lord. You have provided us with the definition of long COVID as provided by the World Health Organization. And I think we can see, I'll simply read it out for you. It's a condition that occurs in individuals, adults and children, with a history of probable or confirmed SARS-CoV-2 infection. Diagnosis is usually 3 months after the onset of COVID-19, with symptoms that last for at least 2 months and cannot be explained by an alternative diagnosis. And you've also provided us with some very helpful information about long COVID. And again, I'll just read this for you. That it affects multiple organs and systems within the body, including respiratory, cardiovascular, neurological, gastrointestinal, and musculoskeletal systems. And the symptoms, which I think is something that we probably all in the general public are aware of, but there are some common symptoms. These include fatigue, breathlessness, cognitive dysfunction. Symptoms may also be new following initial recovery from illness. People experience fluctuations and relapses of symptoms that majorly affect everyday life. Now, 2 documents that you've produced to the inquiry and you've referenced there are surveys that your organisation carried out. One is entitled Impact of Long COVID, and the other is Issues with Employment for People with Long COVID. We'll look at some of the points that you take from that in a little. Now, I'd like to look at some points in the section headed Our Experience of Long COVID Symptoms. I should say that you explain the analysis of the surveys that you've carried out in paragraphs 41 to 43. But in paragraphs 44 and following, you talk of our experience of long COVID, and you provided us with some statistical data, which is obviously very helpful. And what you say is that in October 2022, the ONS estimated that 2.3 million people, so 3.5% of the UK population, self-reported long COVID symptoms. And proportionately, if one takes that to the population of Scotland, then it would mean that at least 175,000 people in Scotland are living with long COVID. Do you think that's accurate?
No, not at all. For various reasons. Self-reported long COVID symptoms, the whole thing around testing or not testing, that was always a very challenging thing in the early days. People being believed if they weren't tested, or so the self-reporting thing of long COVID was viewed negatively, not by us, but by other people, I think. There's no doubt that more people, I'm sure, have long COVID than the numbers there present. And I think that applies today, much more so today, because we don't test and we're not reporting numbers of COVID or long COVID today.
Yeah, I think what you're saying, I mean, I take your point entirely, that self-report, I'm no statistician, but my understanding is that statisticians are always suspicious of self-reported polls, let's call them that. We've got to be very careful about data of that nature. And I suspect that, I don't know, perhaps Mr. Gale intends to do so, but if we had the evidence from a statistician, we could get some insight into how reliable or unreliable such figures were. Is that a fair comment on my part?
Oh, very much.
And I stress a layperson's comment to the statistics. But, yeah.
Ormerod. I think you also indicate that 73% of people who self-reported with long COVID had symptoms lasting at least 12 weeks, and then nearly half of that, those people, 44% in fact, had symptoms more than a year after that, after first becoming unwell. So in terms of the length of residual effects of long COVID, is it quite common in your experience and with your access to the people that you are within your group, that one can be looking at symptoms that are lasting more than a year?
Oh, very definitely, yes.
Now, I've asked you a little bit about relapse and remitting and fluctuating, and I think we can see that both in paragraph 48 and also in paragraphs 55 and following. Just so that we do understand, is the relapsing and remitting nature of the condition something that is common within the cohort of people within your group?
Very common. In fact, I'd say everybody I know with long COVID, it's a relapsing, remitting condition.
What is the effect of subsequent infection?
For me, and I know for many other people, it makes it worse. It makes the other symptoms you have worse. And that may be worse for a while, and then it may improve. Or for some people, unfortunately, it makes them much worse, and people go on a decline, really, after having a subsequent infection.
You again have provided us very helpfully with some of the common symptoms, and perhaps you've expanded on the I think what you describe as the top 5 symptoms, which you say are almost universal. This is in paragraph 51. Then you go on to talk about other symptoms, which beyond the common ones include difficulty sleeping, chest pains, irregular heartbeat, joint pains, and anxiety. And there are some more perhaps nuanced symptoms that you describe in paragraph 53. Also, you do mention in, I think it's in paragraph 50, that most of those who have been afflicted with long COVID contracted it during the first wave. Is that what is the information from your group?
The survey was the information from the survey that people who completed the survey felt they contracted it during the first wave before testing was available.
I'm particularly interested in what you say at paragraph 59, and you deal with it in more detail later in your statement, but it's perhaps a useful point at which to talk about it here, and that is the impact on mental health and well-being. And you talk about the ongoing symptoms of anxiety and depression. Now, we will hear from Dr. Taylor about patients with anxiety and depression. And what I take from her statement is that these are largely people who do not have a pre-existing mental health issues. Mm-hmm. And so from your perspective, you mentioned you had anxiety. You obviously know other members of your group who have had anxiety and presumably depression. Do you know, is it possible for you to say or speculate as to where that comes from?
For me personally, it was, I had a number of things going on in my own life at that time as well. My husband became ill at the end of 2021. He was seriously ill, so I had that as well as my own illness. But I think generally it's around not knowing if you're ever going to improve, if your condition is going to get better, if you're going to recover, not knowing any of that, and being, I think, dismissed by people who perhaps don't believe what you say when you talk about your symptoms. So I think it's a number of things that contribute to anxiety. I think anybody with any chronic health condition knows what the impact of having that is on your day-to-day life, and how you cope with that. You can't help be anxious about the future and the impact on your family and the people you love of an illness that really, for people with long COVID, knew very little about.
We are obviously in this inquiry mindful of our obligation to identify areas of inequality. And in paragraph 60 and following in your statement, you refer to the impact of long COVID on women. And I think you've already said that there is a preponderance of sufferers of long COVID who are women. You've indicated some of the problems that women have experienced and have reported. Could you just indicate what they are?
I think, in chapter 60, we were speaking about 50% of women said they experienced flare-ups or worsening symptoms with menstrual cycle or menopausal symptoms since developing long COVID. And in fact, that wasn't, up until that point, it wasn't anything that our members spoke about in great detail. We asked the question, and that's the answer we got. Mm-hmm. And around about that time, probably a short time afterwards, we had some contact from a couple of researchers who were looking at problems with menstrual cycle and menopausal symptoms in more detail with people with long COVID. So I think it was starting to be more spoken about and brought out into the open. And indeed, since then, it has been acknowledged that that is a major problem for women.
And you take the matter slightly further in paragraph 62, where you say there's an urgent need to better understand the interrelationship between long COVID and their reproductive health to develop treatment plans and reduce further risks to women's health.
Yes.
Is that, do you know if that research and that understanding is developing?
I think it definitely is developing. I mean, we kept in touch with those researchers, and yes, that is developing. How it has influenced clinical practice, I can't say in any great depth that I know much about that at this point.
Now, the next quite lengthy section of your statement deals with various impacts, and you supplement each of these with quotations from the surveys that you've carried out, and that's, if I may say, very helpful, because it's given context to what is said. And obviously, when the inquiry comes to look at this in more detail, we will be looking at other areas of the research, of the surveys that you've carried out. So I'm not going to take you through some of these in great detail, but these include, as you've numbered them, demoralized by the illness, and you give a quote from that. You give the impact on working lives. You give an instance of an example of the impact on family life and relationships. Can I just ask you, however, a little bit about long COVID in children? Because that's one of the areas where you've provided us with some further information. One of the points you make in relation to children is that experiences of long COVID can lead to social stigma. Can you explain that, please? It may be obvious to you, certainly, but perhaps you could just explain it.
I think there's a combination of things for children and their parents, and that's around them not being able to go to school, one thing, mixing with their peers. For parents, it's almost, well, it is becoming perhaps a full-time carer for a child. The parent themselves may have long COVID. There may be other children in the family. So there's a whole range of things around how that impacts on the child and the parents. And then there is the thing of being believed by health professionals and trying to access services and care. And to be frank, care for, if I've said a lot about care for adults or the state of care for adults with long COVID, the state of care for children with long COVID in Scotland is behind that of adults in terms of there being a recognised pathway for care provision. What is going on in different health boards, I don't think that's well known for children. So yes, that is not good, and the impact of that on parents and children who are trying to have some life, live their lives, it's just horrific. I say that as a parent myself. My children are grown, but I just think it is a horrific thing. to have to deal with.
Yes. Again, I don't want to go through these in any detail. You go on to talk about the need for better public health messaging. You go on then to living with a myriad of unpredictable symptoms, the recognition of the chronic nature of long COVID, you've touched on that. You then go on to talking about accessing care and treatment through GP. Again, this is something you have alluded to, and you say that in paragraph 78, people with long COVID often report frustration at accessing care and treatment through GP practices. Is that because of the, what you term the lottery, as to whether GPs understand long COVID?
I think that is part of it. The other thing that is part of it, and some might say it's a hangover from the pandemic, COVID in general, is the access, the ability to access a GP. And some of our members have found that, still find that very difficult, as well as when they actually get there, whether the GP understands long COVID and whether they're willing to work with the patient to look at what care they require is another thing. It's not a predictable thing. It is a lottery.
I suppose, and this is again something you go on to, particularly in the section on improving care and treatment pathways at paragraph 85. And it has as its root, I think, the multi-systemic nature of long COVID. So if you go to your front line of health professional, your GP, with certain symptoms, there then becomes the question as to if you are going to be referred further for investigation, to whom are you going to be referred? Is that a problem?
It is a problem, can be a problem. Many people, myself included, as you've very well described, the multi-systemic nature of it means that there may be a referral required to cardiology, to respiratory, to ENT, to reproductive health, and many of those services themselves are getting to grips with what long COVID means as well. And particularly, I mean, we have had instances, still do, but at this point when we wrote the survey was speaking about, the results of that was that people were requiring I'll give an example of cardiology, a referral to cardiology, and the GP making a referral and cardiology just sending it back, saying, well, that's nothing to do with us. We don't deal with patients with long COVID.
To use a word that we perhaps hear quite often, and you use it in paragraph 85, there's a need for all patients to receive a long COVID holistic assessment of their physical, cognitive, psychological and functional abilities so they can refer to the right specialist help.
Yes. I think what we have always looked for is a multidisciplinary hub or focus for care, accepting that there's a requirement to have specialist treatment accessible within that, and that has always been a challenge.
One other point I'd like to ask you about are underlying health conditions and long COVID, which you refer to in paragraphs 91 and 92. Again, this is probably something you've already touched on, but I was particularly taken with the quote from from your survey, which you give at paragraph 92. Perhaps you would just read that out, please.
COVID has affected every part of my life for the worse. from being a fit and healthy professional geologist working around the world, an ultra runner with an active social life and a regular volunteer, I was too ill to work at all for over a year. And I'm now only well enough to work half-time from home. My income has reduced and my long-term employment depends on my employer continuing to enable me to work remotely, which I have no guarantee of.
You provided us with quite a lengthy section of your statement on accessing care, and again, time is slightly against us, so I'm going to actually just take that as read. But I am going to ask you about the impact on mental health and well-being, because this is a particularly important section. So you repeat at paragraph 105 that negative or unsupportive comments can come from many sources, and they may not be particularly directed at an individual, I suppose. Is that right? And you also talk about the feelings of social ostracism, rejection and devaluation are likely to affect emotional well-being negatively. Can you give a little context to how people with long COVID do feel socially ostracized?
I think feeling socially ostracized emanates from the fact that we feel, I've said there, we feel left behind. People have moved on. COVID is over. Therefore, people don't have long COVID. People don't like to be reminded of what it was like during the pandemic and long COVID, and people speaking about long COVID, asking people to wear masks, talking about ventilation. It reminds people of that period and they don't like it. And that includes friends and family. They just want to move on and get on with their lives. And that's understandable, and so do we. But for us, for many of us, I think, because we are left with compromised immune systems very often, it means we can't get on in the same way as other people do. We need other allowances and precautions to be taken for us to have a life like everybody else wants to have.
And take you finally to the section on the employment survey that you carried out 2022. It's paragraph 107 and following. Again, I don't want to go through this in detail because we'll obviously read it. You give the figure there of 82% of people identify as female, indicating that long COVID disproportionately affects women. And I think that's in accordance with what you've said. I suppose one of the difficulties in relation to employment is there needs to be an acceptance by an employer if it's an employment situation. There needs to be an acceptance and a willingness to be flexible by the employer. Is that right?
Yes.
One of the points you've made in paragraph 112 is that from the survey that you've carried out, you've come to the view that long COVID and its symptoms fit within the description of disability under the Equality Act 2010, and that reasonable adjustment should be made where possible to support workers returning to employment. Do you know if there are any proposals in relation to categorizing long COVID as a disability under the Act?
It's my understanding that some work is underway in that respect. I'm not sure how far it has got, but I know it is underway.
You also tell us at paragraph 115 that nurses and teachers with long COVID face unique problems regarding registration and updating their skills and qualifications. And I think you then give a quote from a nurse who was seeking to renew her, her registration as an RGN. And again, as I've indicated, we'll hear from the Royal College of Nurses in due course. Finally, and with a little haste, Mrs. Ormerod, recommendations for the future. Again, we can read what you say, but accepting for the purposes of your evidence what you've said there, is there anything further that you would like to say to the inquiry at this stage before you leave us?
Thank you. I would like to say that there's an insistent claim from Scottish Government that money allocated for long COVID services in 2021 has been well spent, and that services have been developed and people's needs have been met. And the allocated money for long COVID service development equates on average to £12 per person with long COVID. We know that some of this money has not been spent, and although some services have been developed, it's clear they're not meeting people's needs and they're not easy to access. And two recent reports, just in the last couple of weeks, from Chest, Heart and Stroke and the Health and Social Care Alliance have also validated those claims from our members as well. So I suppose I would say the Scottish Government might be better placed to ask, so what might we do differently? How can we move forward? And we're also told that funding may cease in 2025. What will happen then? Will services go back to the same as they were before? Will long COVID services as they are be absorbed into existing services? And this is all within the context of long COVID being predicted that 200 million people may develop long COVID in the next decade. So we have a huge challenge, and it's just how we look at it differently, and we're very clear about what we want. We want to be listened to, and for lived experience to be at the heart of ongoing solutions. And that can only happen with a commitment from Scottish Government to a dedicated plan to ongoing funding for the continued work of the development of long COVID services. Thank you.
Well, thank you very much, Mrs. Ormerod.
Very good. Thank you, Mrs. Ormerod.
Thank you.
1:30, I think, Mr. Gill.
Yes, my lord. It's Mr. Stephen again.
It's Mr. Stephen. Very good. Thank you.